at Washington, D.C., and also to everyone attending via webinar. My name is Johnny Ben Shalom. I'm a senior researcher at Mathematica and project director of the Stay at Work and Return to Work Policy Collaborative. It's my pleasure to welcome you to our Disability Policy Forum on promoting stay at work and return to work policies. Mathematica Center for Studying Disability Policy was established in 2007 to help build the evidence base for sound, effective disability policy. Findings from CSDP research can help inform disability policies and programs across the nation to better meet the needs of all Americans with disabilities, and one way that we do this is through our disability policy forums. Today's forum is co-sponsored by the Stay at Work and Return to Work Policy Collaborative, a project funded by the Office of Disability Employment Policy at the U.S. Department of Labor. Through this initiative, and with support from ODEP and our partners at EconSys, we are identifying and promoting effective return to work policies and supports for the millions of workers in the United States who develop a medical condition that hinders their ability to work. To clarify the magnitude of the problem, according to our best estimate, about 2.5 million workers per year experience a disability or other work limitation that causes them to leave the workforce at least temporarily. For comparison, 2.7 million workers applied for Social Security disability insurance in 2012. Today, many of these workers fall through the cracks of a fragmented system. They have to navigate, pretty much on their own, various uncoordinated service providers and programs that are often poorly equipped to deal with their situations or plainly too late to help. Many of these workers enter SSDI and 24 months later Medicare, and those with low incomes may also qualify for SSI, Medicaid, and various in-kind supports. These workers in our society pay a high price. Their standard of living drops. They often do not get appropriate care for the condition, and they're too often marginalized from society. In addition, the government loses tax revenues and pays for the public disability, health, and welfare benefits that these workers might qualify for. Evidence shows it doesn't have to be this way. In support of the twin goals of reducing labor force exit and SSDI entry, the Stay at Work and Return to Work Policy Collaborative has established and facilitated 3 policy work groups, each assigned to identify, develop, and share actionable policy recommendations that can help people stay at work. Today, we will hear from the leaders of each of these policy work groups. First, David Stapleton, Director of Mathematica Center for Studying Disability Policy, will share policy recommendations for states and the federal government on ways to expand access to evidence-based early interventions to those workers who would benefit the most from them. Next, Kevin Hollenbeck, Senior Economist and Vice President at the W.E. Upjohn Institute for Employment Research, will share policy recommendations, primarily for DOL, on ways to encourage employers to retain or hire these workers. Finally, Jennifer Christian, President of Mobility Corporation, will share recommendations for establishing accountability among key stakeholders in order to reduce job loss after injury or illness. We are also honored to have Jennifer Sheehy here with us. She should be here momentarily to discuss these recommendations and put them in the context of current federal policies and initiatives. Ms. Sheehy is the Acting Assistant Secretary of Labor for ODEP at the Department of Labor, and I'd like to thank her and the project team at ODEP, some of who are here in the room, for supporting the work presented here today. Please note that the recommendations presented today are outlined in 3 new policy action papers, which were just released to the public this morning. If you haven't received an email yet, you should look for it in your mailbox soon. You can access these papers along with their companion 2-page fact sheets through our project website on Mathematica's webpage. Before we get to the presentations, I have just a few housekeeping reminders for the audience. Our session includes both an in-person and online audience that is joining us via live webcast. To help ensure the highest possible sound quality for our webinar participants, we ask that those of you here with us in DC silence all of your electronic devices. Please note that we are video recording today's session and may capture images of some of you in the audience, and this recording will be posted on our website next week. If you're on Twitter, please follow us along with today's event and submit your questions via Twitter. Our event hashtag is #R2WPolicy. And finally, please note that today's presentations and the papers on which they are based do not necessarily reflect the views or policies of ODEP or any other federal agency. After Kevin speaks and after Jennifer she speaks, we will break for questions from both our in-house and webinar audiences. So we'll have 2 separate Q&A sessions. For those of you participating via webinar, please submit your questions electronically through the Q&A panel on your screen at any time during today's forum, and we will alternate your questions with those from our in-house audience. Now I'm pleased to turn the podium over to our first presenter, David Stapleton.
Put that on my lap. Get started.
Thank you, everybody else, for being here, and I imagine more people are going to be trickling in as we proceed. The title of my talk today is "The Right Help for the Right Workers at the Right Time Can Keep Them on the Job." This is based on a project under which we tried to identify the types of workers who are most likely to leave the labor force and enter Social Security disability insurance because they lack access to services and supports that could help them continue to work. It's a target population for expansion of public financing for such supports. It would be attractive. It would potentially help workers a great deal, and it would also reduce rather than increase public expenditures because of savings for SSDI, Medicare, and other public programs. So we assembled a very strong team of subject matters to work on this topic. I'm not going to read you all their names. One of them is in this room, and I won't say who that is, but he has a very nice last name. And much of what you're going to hear today, really, they're the primary source for it, as well as the extensive literature that we consulted as we developed this paper. I'd also like to thank Yoni, who was an integral part of this effort, as well as Steve Bruns and Hannah Burrick and Mathematica staff who provided us with support. So first what I want to do is to define what I mean by the right help at the right time. We've adopted evidence-based early intervention, or EBEI, as shorthand for such assistance. And then I want to quickly take a look at those workers who are most likely to benefit from an expansion of EBEI. That is what we have defined to be the target population. I'm going to skip over the next item on my list because I want to save more time for the recommendations at the end. And those all concern the implications of our findings for practical steps that policymakers and program administrators can take to expand access to EBI to those who are in the target population. So what do I mean by EBI, the right help? Well, there's extensive, rigorous evidence that providing certain mixes of services and supports to workers who've experienced a major medical problem can help them stay in the labor force and avoid becoming dependent, avoid income loss and avoid becoming dependent on long-term income benefits. Successful intervention may involve medical care, improvements in medical care over what they would normally get, physical, occupational, or vocational rehabilitation, various sorts of technological assistance, accommodations, and maybe phased re-entry into the labor force. It usually involves coordination of services in some respect because multiple providers and the employer and the individual are involved. And it often also involves temporary cash supports and also incentives for employers to maintain the employment relationship. Sometimes it also involves incentives for providers. So all those things can be involved, and exactly what's used depends upon the characteristics of the worker and the environment in which it occurs. There is a consensus that the right time is usually while the worker is still attached to the employer, even if it will be a long time before the worker can get back to the job. According to the literature, the main reason for this is economic. It's not a technical reason, it's an economic reason. And that's simply that the earlier intervention starts, the faster the recovery of function is going to be, and the shorter will be the absence from work. The right workers for expansion of EBEI are those who meet three different criteria that we developed. The first of these is those who are likely to enter SSDI. This is where the savings comes from, right? If we aren't successful in slowing down entry in the SSDI, it's hard to produce program savings for SSDI or for Medicare. The second criterion is those for whom EBEI is likely to succeed. So if we start providing services to workers who aren't going to benefit from those services in the sense of being able to continue to work, we're just throwing away money. It's hard to eliminate that, but we certainly don't want to do so unnecessarily. So that's the second criterion, and you can see, as depicted in this slide, they're actually a minority of those, they may be a minority of those who are likely to enter SSDI after they experience a medical issue. We really don't know, though. It's possible they're a majority. We'd like to think so, but it's, I think, sensible to think that they're a minority. The third criterion is that currently they have limited access to evidence-based early intervention services. And if we only expand public funding for evidence-based early intervention services for those who already have access via maybe workers' compensation or private disability insurance, then the primary outcome would be to displace the private funding with public funding. It wouldn't mean better outcomes for workers, and it certainly wouldn't mean savings for the government. So that further reduces the target population, and we finally get to the right workers, those who meet all three of these criteria. I think a good case can be made that there's another good group of right workers in this target population, those who have limited access to services now, and they struggle with employment because of limited access, but they don't meet SSA's stringent eligibility criteria, or they're just so determined to stay in the labor force that they manage to do so but have to endure many expenses and difficulties in order to do so. Many of these people may be among those who are, about 1 million people a year who are denied applications denied awards of SSDI disability benefits. They apply and are denied. So that's this group here, the more right workers, with a question mark. And while expanding to workers' services to this group may be a very good thing from a policy perspective, it is not likely to produce a lot of savings to the federal government or any government. So I'm going to skip this slide. I think one other point is that a lot of the evidence that we have about the success of evidence-based early intervention comes from the private disability insurance and workers' compensation industry. And that's because at least some carriers, many carriers, are actually, part of their business is providing those types of services, and they've done their own research, and other research has been done about the provision of those services. So workers who are covered, or whose injury is covered by workers' compensation or private disability insurance, they may not be in the target population, and probably most of them are not. However, it is also true that the quality of the evidence-based early interventions available to workers who do have coverage varies all over the map. I think that's especially true in workers' compensation, which is regulated by the states and varies a lot across states. So some of those workers will be in the target population, but we think they're probably a minority of those workers who are in the target population. So we've looked a lot at the characteristics of workers in the target population, and based on the literature, what we found is that they are disproportionately have low socioeconomic status, they have low-paying, low-skilled jobs, and often work for small or medium-sized firms, not for large corporations. We also know that a majority of those who enter SSDI have musculoskeletal conditions, especially lower back pain, or they have significant mental health problems. They may have other problems too. We know less about those other problems because the Social Security Administration only has the data on their primary conditions and sometimes secondary conditions. But given the strong evidence on successful interventions for musculoskeletal and mental health conditions, which I skipped over in that last slide that I just went by, but that's actually where the evidence is strongest, for those type of conditions, not necessarily for these same workers, but for workers with those types of conditions. That's where we know how to intervene best and keep people in the labor force. It seems to us that those who are likely to enter SSDI and who have either musculoskeletal or psychiatric conditions are the ones who should be given first priority in the expansion of EBEI services. I said I was going to skip this one and go right on to the recommendations, so that's where we are now. We first look at what could we recommend to state governments. So these are actions that we think that state governments can take within current law, obviously limited by current law and certainly limited by funding, but things that they should work into. look into. So first of all, the Workforce Innovation and Opportunity Act, which was passed in 2014, so it's new. States are still learning about it, trying to adapt to it. It requires states to develop strategic workforce plans. And we would say that including expansion of EDI services to the target population ought to have a high priority in those plans. Our understanding is it does not have a high priority now. They're not focused on this topic. But certainly, WIOA is crafted in a way that supports that. And we would urge states to consider how they could take advantage of the changes in WIOA and the systems that they already have in place to target more services, and especially evidence-based services, to this target population. States can also look at expansion of EBI services to the target population under other programs, not under WIOA. It's certainly workers' compensation, which is regulated by states. And also 5 states have short-term disability programs, which would be an ideal source for identifying workers early on who experience problems that may lead to labor force exit. But to our knowledge, no states are doing that currently. So the second major point we made is that states could look at their own employees. They are, after all, very large employers. And many of the workers who are in the target population may be workers who are state employees. We don't know, and this probably varies a lot by state. But take a look at your own employees, see which ones are in the target populations, are not getting evidence-based services now, and figure out how to expand services to those employees. So the next set of recommendations, the other set of recommendations concerns actions for the federal government, and these vary quite a lot, but the first one is support the efforts of the state governments, encourage states to do the types of things that I just described, make sure that the funding, the federal funding that is already available to states can be used for the purposes that we described when it can, and maybe address issues when it can't. The second one concerns encouraging federal contractors to optimize the use of evidence-based early intervention as a tool for achieving their 7% disability employment goal. So most of you may know, and it's certainly anybody who's a federal contractor in the room, like Mathematica, knows that there is now an aspirational goal that every federal contractor should have among its employees 7% of workers who have disabilities. And that's a really hard goal to achieve. And one way you can do it is go out and hire people. But we think that another way to achieve it is to make sure you hang on to the people you have who experience a significant medical issue that's likely to be disabling, but with some early intervention can help them continue to be workers and productive for you. The third point concerns the federal government as an employer. And just like with the state governments, they should be looking at optimizing the availability of evidence-based early intervention for their own employees. For the federal government, one thing that makes this particularly attractive is that the federal government actually pays for all of the cash and health benefits that disabled federal employees who are no longer working receive. It doesn't matter whether it's federal workers' compensation, whether it's Social Security, disability insurance, and Medicare, or whether it's disability pension benefits from the federal government. That's all paid by the federal government. So the savings from keeping workers in the labor force rather than getting those benefits would all accrue to the federal government as it So the final point concerns supporting expansion of the evidence base. So we think the evidence base is actually very strong, and there's a lot there that people aren't really familiar with, but can really be used to guide the expansion of evidence-based early intervention services. But there are major gaps, limits to it, and we think there are a number of things that the federal government can do. We give priority to looking at state efforts to expand EBEI services that we've talked about already, supporting tests of pilot programs that would offer EBEI to the target population, particularly subpopulations that are hard to get to now. And then also to support use of proven proprietary tools which are out there and being used in the private sector, but not by federal or not by public agencies, in their own efforts to expand EBEI access. And then also to rigorously test other tools that may be proprietary and promising, but don't have an evidence base to support them. So the final point is, we think there's a lot that could be done now. And it's really important, however, that to achieve success in both the objective of reducing needless exit from work because of a medical issue and entry into SSDI, and also to reduce growth in federal and state expenditures to support working age people with disabilities, it's really important to keep your eye on the prize, and that is to get the right help for the right workers at the right time. Thank you.
Well, I want to thank Mathematica and the Department of Labor for sponsoring this work and including me in it. And I want to thank those that are here today and tuned in on the webinar. My paper and presentation really complements Dave's and Jennifer's, for that matter, by focusing mainly on policies or practices that will influence employer behavior in order to increase the retention of workers or the reemployment of workers who may have been separated from their jobs. My experience and expertise is really in the workforce development world and improving employment outcomes for disadvantaged workers. And as I will show you briefly, the target populations very much overlap. And so I'm basically trying to bring some of the experiences from the workforce development world to helping workers who have experienced a disability or a major medical event. As with the other groups, I had the good fortune of working with a terrific group of folks that helped me a lot in going over the literature and considering different policies. Again, I won't list their names for the sake of time. I'd also like to thank Yoni and Dave and Steve Bruns, who helped out a lot on the project. Basically, real quickly, I want to talk about the target population and some of their characteristics. Talk a little bit about retention and accommodation from kind of a labor economist's viewpoint. And then mainly I want to spend most of my time here talking about the recommendations that our policy work group came up with. So in terms of the target population, as you mentioned, we believe that around 2.5 million individuals experience a disability during the year that affects their productivity. And that relates closely to the number of applications for SSDI. In terms of the target population, who they are, I looked at some current population survey data. And in this graph, if the red bar is taller than the blue bar, that means that population is disproportionately included in the disability. And that means here that women are disproportionately included, minorities, and again, as David had mentioned, low-educated, low-skilled folks. Not shown on this chart is age, but they tend to be older on average than the average worker. The mission of our group is basically to improve upon the status quo, to improve the amount of retention and the amount of reemployment of folks. To remind us all of what is the status quo, I've listed them here on this slide. We have two pieces of federal legislation, ADA and FMLA. In a number of firms, there's private disability coverage, workers' compensation, of course, in the states that have that program, and if the event occurs at the workplace. We all have a workplace culture. Some cultures are more supportive of retention than others. And then there are a number of social safety net programs. I guess the point that I wanted to make here is that they're not universal. They don't cover everybody that would have an event, and they have different eligibility criteria. And so the status quo is fragmented, and some populations may not be effective. In terms of retention and accommodation, there's basically two parties involved. There's the employer and the worker. And the policy or practice that's going to affect retention is either going to be provide an incentive or penalty to one of those parties, that is a carrot or a stick, or there might be what we economists call information externalities, a lack of information. So another type of policy might be to try to increase the amount of information there is available to employers. In terms of reemployment, there's a third party involved. We have a worker and we have a potential employer, but usually there's also a labor market intermediary that might be the public workforce development system or some other system. Much like when you're buying a house, there's a buyer and a seller and usually an agent in between the two. And so policy can affect any one of those three parties when we get there. So the policy work group that I worked with considered a lot of different policy possibilities and suggestions in the literature. And we basically decided to take kind of a short-run, immediate criterion for our recommendations. We thought carrots would be more feasible, more acceptable than sticks, so incentives better than increasing penalties. As feasible, we believe that policy should be tested with pilots or demonstration programs and rigorously evaluated. And then we also believe that some of these nudge experiments that build on behavioral economics are a reasonable thing to offer as well. So I'm going to talk about 6 of our recommendations, 3 in the area of improving retention, 3 in the area of improving reemployment outcomes. In the paper that was released today, we actually have 10 recommendations. And as I say, as a policy work group, we looked at many. Oops, I went too fast on that. So our first recommendation in the area of retention is to do a RCT, randomized control trial of providing information. There's a lot of great information, a lot of it developed by the Job Accommodation Network. And we suggest that it would be reasonable to set up some experimentation on sending different types of information to different types of employers and then tracking the outcomes of that. And if we find, positive results, then we would urge wider dissemination of that information. The second recommendation in the area of retention is to encourage the development of something called employment resource networks. Excuse me. These are entities that are beginning to be developed across the country in which small to medium-sized businesses usually, although in some ERNs it's large businesses, but they get together and they do a partnership with a public agency such as a human services or a one-stop agency to fund what they refer to as a success coach or a retention specialist. There's been some study, these are fairly new on the scene, there's been some study of their effectiveness. We didn't find any evidence of the extent to which they're actually working with disability in the disability arena. So we think that's an obvious place where there needs to be more evidence. And if they are, to find out what's effective. If they aren't, to start to provide some technical assistance and information to work in that area as well. The third recommendation in the area of retention accommodation is to set up a pilot to demonstrate a program that my co-presenter Dave Stapleton named the Ticket to Stay at Work, which is essentially building on the Ticket to Work kind of program, but working through private disability carriers to provide incentives or workers to provide stay-at-work services or financial incentives. Moving to reemployment, our first recommendation is just to let's monitor and see what's happening under WIOA. As Dave mentioned, the framework of that legislation is to integrate voc rehab with the workforce development better. Let's ensure that the data systems are capturing the reemployment of this target population. And then using administrative data, we can analyze the data to see where it's being done effectively. A second recommendation from our group is to expand the Ticket to Work program to make it available to workers who have lost their jobs but have not yet applied to SSDI. The idea here is potentially one reason Ticket to Work is less than effective is because workers on the rolls have this alternative already, and maybe it would be more effective to get to them before they get on the rolls. And then the third recommendation of the group came kind of from the dislocated work literature of setting up a pilot or a demonstration and evaluating that of a wage loss insurance program, where if a worker becomes separated from a job, takes another job at a lower wage because of lower productivity or other reasons, there would be an insurance scheme that would partially or wholly make up the difference in wages. So to summarize this presentation, I've presented three suggestions in the area of retention or accommodation, the idea of providing information and through a random assignment type evaluation, encourage these ERNs that are popping up across the country, and demonstrating this Ticket to Stay at Work program. Three ideas in the area of reemployment, just monitoring and analyzing administrative data from WIOA, expanding the Ticket to Work to eligible individuals, and a pilot study of a wage loss insurance program.
Thank you, Kevin. So we're going to take now a short break for a few questions for Dave and Kevin before we proceed with the two Jennifers. Do we have a question from the webinar?
We do. Dave Stapleton's question is for you. This is specifically regarding your slide on actions for the federal government and where you note support expansion of the evidence base. One of your bullets is support use of proven proprietary tools and rigorous testing of promising tools. Charles Carr asks, could you give some examples of proven proprietary tools?
I don't, can you hear me okay? I don't want to point to specific tools because my memory isn't good enough to pull them out, but the types of tools I'm referring to, there's a variety of different ones. I think they start at sort of identifying workers who need certain types of services, figuring out what they need, predicting how long it might take them to get back to work, what the process should look like, monitoring progress, et cetera. So there are a number of different things that we discovered, but we also found that the evidence base on many of them was it was either not public or non-existent. And we know private insurers use them because they think they work, but the information is not in the public domain. So the motivation for that particular recommendation was more for doing more testing in the public domain of some of the tools that are being used, and then trying to adapt them to public programs.
Thanks, Dave. I'll take a question from the audience. Please state your name and affiliation.
Joanne Schneider, George Washington University and Chrysalis Collaborations. This is kind of across the two of you. I agreed with everything you said about who the target population is until you came to the conclusions. And the anthropologist in me plays devil's advocate and says, well, if we're talking about folks with low to medium skills, which means if they're injured, they're probably going to need to be completely retrained. talking about small to medium businesses, which don't have time or don't care or whatever to do additional insurances or whatever, and if we're talking about today's human resources world where you've got all these young people who just want to get these older people out the door anyway, right? And if we're talking about doors and the one-stops that don't have enough funding and now think that all they should be doing is getting veterans and youth through, trust me, I've been dealing with them even as we speak. How do we make this work? So I'd love to hear more about these insurance plans. And David, what policy needs to change to get these folks the funding to be able to do what they need to do? Because they don't have enough funding to do all these populations.
That's a rather long question, lots of parts to it, and I can't answer all of it. I realize that the goals, the right worker, right sports, the right workers at the right time, are very challenging, and that's kind of the point of the project, and also to point out where there are opportunities. I don't think any one thing is going to solve the problem. I do think it's important from a policy perspective to recognize that the cost of not providing the right services to the right workers at the right time are really, really high in terms of SSDI entry and in terms of loss of productivity. And so I think pointing out that is helpful. I do think there are mechanisms in place in current law that would allow states to take initiatives here. I think given there are other issues, it's really hard to get them to devote resources to this. And so I think all your premises are on target more or less, and I don't have an easy solution, an easy answer to any of them. I would say that, as we're debating what to do about the SSDI trust fund, there has been a lot of discussion about early intervention and the potential benefits to the SSDI trust fund as well as to Medicare. And I hope that is going to provide some impetus to move forward in this direction. But would
you like to add anything?
Sure. I guess, again, I also agree with many of your premises. And in my thinking, there's kind of two approaches. You can sort of do some marginal changes to make the world better, or you can, do wholesale, big think kind of changes. I'm of the opinion, and I think my work group is of the opinion, is let's work at the margin. Let's work at, given the strained fiscal conditions and all the problems there are, let's work at the margin and try to improve things instead of trying to bite off more than we can chew. But even at the margin, and even going toward some of my recommendations, I think it's going to take setting more priority from all of us, from making sure that this rises to the top of the policy agenda, and there's more priority given to it.
Kevin,
Can I come in on this one? I realize I have no brief yet, but I can't resist.
coming out of your time.
It's coming out of my time. All I would really want to say is, unless you're willing to say that nobody that has all these characteristics is working today, then you have to ask different questions. What enables people who have all these characteristics to work? And otherwise, what you're doing is you're writing them all off.
And with that, Jennifer, we'll move on to you.
Okay.
Self-introduction.
Okay, so my topic is establishing accountability to reduce job loss after injury and illness. It actually started as a different topic called promoting work as a positive health outcome. And as I started to think about it, I said, I'm not interested in discussing platitudes. I'm interested in making things happen. And I started realizing what we have to do is establish accountability in order to reduce job loss after injury and illness. Because right now what we have in our society is a gap through which people are falling. Doctors don't feel that helping people actually stay at work, return to work, and stay and keep their jobs that is their responsibility. They don't think that's medical. And on the other hand, at the employer side of the equation, they don't think it's their responsibility either because they think it is medical. So what we have is the people who develop injuries and illnesses have no one there to help mitigate the impact on their lives, and they experience delay, uncertainty, abandonment. Their life is in limbo for a period of time. They have job loss, and they change their definition of who they are, which results in needless work absence, job loss, and withdrawal from the workforce. So I was assisted in putting this paper together not only by the members of the policy work group, but by over 20 other experts in various sectors of society. I'm grateful to them all. We had wonderful conversations, but none of them are responsible for any of the recommendations. I'm the one that stuck my own neck out. So this paper, we're going to lay out 4 premises that will serve as a foundation for the policy recommendations. And I want to describe a little bit the 4 individuals who have the most influence over the outcome in a health-related job disruption. I wanted to summarize the status quo in the private sector and public sector marketplaces now and how the stay-at-work and return-to-work process too often works today, then make 3 major recommendations for change and suggest several specific ways to actually make these changes happen. So here are the 4 premises. A healthy adult life should mean participating fully in life and engaging in productive activity, whether paid or unpaid, for as long as feasible. We're a social species. We were born to contribute, to play a role, and to contribute. And this should include people with chronic conditions and disabilities. And maximizing the number of adults who are self-sustaining taxpayers and contributors to the economy is vital to our country's future. Thirdly, today, none of the 3 professionals who usually get involved in a workers' health-related employment disruption feels responsible for helping people keep their jobs, nor does the organization in which they work, nor do they coordinate their efforts. This was a giant surprise as I started to think about this. Nobody feels responsible when somebody loses their job. The current situation does reflect the complex, fragmented, and dysfunctional nature of our healthcare and social welfare systems in both the private and public sectors. So here are these 4 frontline players. First of all is the affected individual. This is the person who has the power to decide how much effort to make to get better, and who needs and comes up with their own strategy for the best way to handle the situation. Sometimes it's a cockamamie strategy. Sometimes it's a dysfunctional, completely destructive strategy, but it's their job to come up with that strategy. And then there are 3 professionals in separate worlds: the treating doctor or the healthcare practitioner who works in a healthcare delivery organization and who is authorized by law and business practice to make decisions about treatment and stay at work and return to work, and enjoys quite a lot of respect and power from the other stakeholders. The second one is the workplace supervisor and or the human resources professional in the organization in which this individual is working, who acts on behalf of the employer as employer and who decides whether and how hard to look for a solution. And lastly, it's the benefit claims representative, the payer, who's writing the checks, who's acting on behalf of the health plan, the workers' compensation or disability benefits program, whether it's private or public. And they are deciding, again, how much effort to make and what to pay for given the rules. So the affected individual, who's usually a person who hasn't had much experience with health problems and who is a person who hasn't had much experience with administrative bureaucracies, is thrust into a double maze. They're in both the healthcare system and they are in whatever benefit system they're in. And as I said, they're more or less left to find their way through it. And sometimes they are assigned somebody who's navigating, but that person is mostly helping them get benefits rather than helping them get back out to this side over here where the normal rhythm of life resumes. So how it looks to these 3 professionals is that the treating doctor, their focus is on diagnosis and treatment. I'm medically trained. I know that's what we were trained to do. And we are not trained in how or why we should give helpful stay-at-work and return-to-work advice. In fact, we've been basically pressed into service by other parties, and we serve as the designated guesser to give them the answers of things they want, like what is it safe for this person to do, how long do they really need to be away from work, do we estimate their functional capacity is. We haven't been trained how to answer the questions, and the science behind our answers is non-existent, and the time we spend on stay-at-work and return-to-work issues is unrewarded. In general, doctors are unaware of workplace realities and potential solutions. You know, like they went to medical school and they work in a medical practice. The workplace supervisor and the human resource professional, their focus is on administering the employer's policies and procedures. They're not typically being evaluated on outcomes, for example, total dollars and benefit costs per episode or job loss. They are unsure how to interpret medical advice. They often, just like when the doctor says something, that's the revealed truth. And they are usually inexpert at the stay-at-work and return-to-work dialogue and finding solutions. It is only large employers that have someone working at this stay-at-work and return-to-work interface. And then the benefit claims representative, their focus is on administering the benefits program correctly. The health payers are focused exclusively on health care costs. They don't actually have the slightest interest in time away from work or job loss. And even the workers' comp and disability benefits people are typically not accountable for overall outcomes of individual cases. The total cost per case, the lost work days per case, how many people are losing their jobs, and they are unfamiliar with workplace realities and employers' obligations. They went to high school, they went to college, they went to work for an insurance company. So each one of these three individuals who has so much individual personal power over the outcome works in a context, and they work in an environment. They work in an organization, so they work in an employer, they work in a healthcare delivery organization, they work in a payer, a health plan, disability carrier, and those organizations are in turn influenced by other players, by intermediary organizations and vendors in each one of the industries, by advocacy groups, labor unions and lawyers, by social service and charitable organizations, by the local and state and federal government agencies that have established policies or provided other kinds of, or are providing other kinds of services, and obviously the state and federal legislatures which are writing laws. So that's the context. Basically, people are left on their own. And so our recommendations, first of all, is that we ought to set the preservation or restoration of full participation in life, especially return to paid work for those who do experience health-related employment disruptions, as a major purpose and an expected outcome of health care services, disability benefits programs, and workers' compensation programs. It's very odd that this is not now part of what we do expect from these programs. If you think, as a taxpayer or as an employer, what would be a good return on your investment in healthcare services for your employees, it would be that they are able to resume normal lives and enjoy being full participants in society and do their jobs, right? But that is not part of our conversation about the value of healthcare services today. So we should consider these outcomes as positive indicators of good quality and value, and we should consider avoidable impairment and work disability as poor outcomes and potential indicators of lower quality and value. Second recommendation is we should develop formal mechanisms to establish and enable accountability for these outcomes among the three professional players with the most influence on them. And because distinct forces are operating, there are different forces at play, separate mechanisms will be required to make the right thing happen more often and the wrong thing happen less often. And enable for these three players to carry out their accountabilities and their portions of helping people stay employed, what part of the mechanisms will need removing and minimizing operational and administrative obstacles to information sharing and teamwork among these participating organizations. And the last recommendation is we need to design and implement an array of strategies that's powerful enough to effectively disrupt the forces that are perpetuating the current suboptimal marketplace equilibrium and deliver transformational social change. So the relevant strategies to actually achieve that disruption and that transformational change begin with leadership on social and health policy, and other strategies include public information and social marketing campaigns, incentives for organizations in the private and public sectors, new legal and regulatory mandates, and changed priorities for research and development. So after kind of making those big sweeping things, I said, okay, what are we going to come up with that will actually accomplish these things? So in the rest of the paper, you'll see specific suggestions for how to do that. And they can be grouped into three buckets. First is capturing and consolidating data and creating metrics. Second is encouraging frontline players to work toward positive stay-at-work and return-to-work outcomes and providing federal leadership. So with regard to data and metrics, I recommend designating a federal agency to expedite data collection by key stakeholders, sharing of data, and the development of metrics that will facilitate accountability. There is some work ongoing already in the private sector around this. So we're talking here about a private-public sector collaboration on developing and starting to use these metrics. And also, though, that we should be requiring that outcome measures for federally funded research should include the impact on people's lives, function, and jobs whenever applicable, instead of ignoring it. And lastly, this is probably one of the most bold recommendations, is we should require the job losses that are caused by medical problems be tracked and reported to the Department of Labor, similar to OSHA. Right now, across the country, we are tracking how many people have injuries, how many people have hospitalizations, how many people die as a result of work-related injuries. We have no real knowledge of who it is that's losing their job and from what employers and for what reasons. And if you can't measure it, you can't manage it. In terms of encouraging frontline players, we want to reward healthcare professionals for best practices in stay at work and return to work by creating billing codes and paying for them. Right now, there is no incentive for doctors to learn how to or really pitch in the stay at work and return to work process because they're a sucker if they do it. They're not paid. So we want to provide stay at work and return to work services also to workers without access to them. And this sounds very much like David's ticket to stay at work or Kevin's ticket to stay at work program. But we did come up with a potential way of funding it by assessing fines when employers don't try to keep workers or help them find new jobs. There should be consequences for employers that throw away employees. And lastly, create positive models to serve as examples or guides, as well as incentives for stakeholders to deploy them. For example, a certification program for employers that's analogous to OSHA's Voluntary Protection Plan program with recognition for meeting the criteria. And a sample health plan that does include stay at work or return to work services. Model curricula for educating healthcare professionals, as well as suggestions for how to actually get them trained, and an interagency collaborative to serve as a role model by improving outcomes for federal workers. And lastly, it's essential for there to be strong federal leadership because the government is who articulates the voice of our society. So we need to add participation in work in society as major indicators of health in the nation's public health agenda, in the Healthy People 2020 or 2030 agenda, and define what health means for people living with disabilities. We need to convene a panel of experts to come up with a plan, strategies, and tactics for policies that will disrupt the status quo and deliver the desired changes. This needs to be a multi-stakeholder effort. And we need to develop a set of key documents that will serve as a persuasive, easy-to-read, evidence-informed foundation for action and change. Documents like this is what made a big difference in the United Kingdom as they moved to a national agreement that work is good for people and we should encourage people to have full lives. And lastly, conduct a campaign to inform and shift the beliefs of influential target groups using these key documents and revise federal research priorities to fill knowledge gaps. Federal leadership really is essential because at this point there is no major organization anywhere in the United States focused on preventing needless work disability, job loss, and workforce withdrawal among working adults after an injury, illness, or changed disability. If you know of one and I've missed it, please let me know. I've been looking since 2006. And so the solution, I think, here is to designate one federal agency and empower it. Another possibility is for a very rich foundation to take this on and lead and drive this whole initiative forward over time and expect to monitor and report progress in implementing the recommendations in sequence and on specific dates so it actually is accomplished. So lastly, we really do have a gap not just between workplaces and between doctors' offices. We have a gap between the private and the public sector, with neither sector feeling it is their responsibility to help people who develop health-related employment disruptions to keep their jobs. Thank you.
Thank you, Jennifer. So as a reminder to our webinar audience, we'd love to hear from you. Please submit your questions now via the Q&A panel on your screen. And after our discussant's remarks, we will first direct our questions to Jennifer Christian and Jennifer Sheehy before we direct questions back to, before we open up to general Q&A for all of our speakers. I'd now like to welcome Jennifer Sheehy to give us her thoughts about the recommendations we have just heard and how they might inform federal policies regarding return to work policy.
I think my microphone is on. Thank you, Jennifer. The two Jennifers actually work very well together, not just on return to work. But, and thank you, Yoni. Thank you so much to Mathematica for hosting us here today. Thank you to my office for funding this great work, because I have just been so impressed by the products that have come out of this, the really thoughtful work and the people that have been involved. It's like we have so many of what we would call the dream team on early intervention, return to work, and looking at these policy areas. And it's been fascinating to really look at and consider some of the recommendations that have come out of the policy papers. And I can't say I disagree with the recommendations, but I did have some observations, especially wanted to relate it to some of the work that we are doing and some of the opportunities that we have right now. And I have several of our Office of Disability Employment Policy co-workers here today, and I just want to recognize them. We have Annie Schneider, Karen Williams, Lindsay Field, Janet Voigt, and Mike Reardon, who have all been involved in some way or another. So your ideas are being carried forward. We have a lot of great people who are thinking about this and thinking about what we can do as a federal agency. The Office of Disability Employment Policy is a small federal agency in the Department of Labor that looks at policies in the other federal agencies around the federal government and in the Department of Labor, and tries to make recommendations so that outcomes for people with disabilities in employment can be improved. So we really look at the interaction and intersection of vocational rehabilitation, education, transportation, health care, and all the job training supports that we have access to in the Department of Labor. And I think one of the things that really struck me is that we are really looking earlier in the process, which is what is necessary. I think Jennifer Christian might have at one point coined the term the sweet spot of early intervention, where someone is attached to work and you have a very limited window during which anything you do is really going to affect the outcome, and after that sweet spot, and maybe as short as 12 weeks. And anything that you do after that is going to be a lot more work, a lot more investment for less of an optimal outcome. And then, of course, once they are connected to the Social Security Administration, they don't have as many resources and benefits. So we have to look at where we can touch people and who touches those people before they apply for SSDI. And I think that's why I'm glad we're sitting in the Department of Labor, because we do have access to a lot of those supports and the people who are in that system. So we know where some of the folks identified in the target population, how to reach them. You know, we administer unemployment insurance. We fund the American Job Centers, and we are connected as a sister partner to, thank you. We're connected as a sister partner to our vocational rehabilitation system in the Department of Education. So I really am glad that we can look at some of these recommendations and ultimately, like, could we do something with the population that we touch? And we look at what the federal role is. And all these ideas are good, but as has been pointed out, there are a lot of stakeholders involved. And the federal role, something that we can do, we can coordinate. We can coordinate with our sister agencies. We've been successful at doing that in some areas, not so much in other areas. But we can work together. We can fund demonstrations together. And in a limited budget environment, we really have to look at that. You know, several small agencies contributing or participating in something. We can be a bully pulpit. I mean, we can do messaging, and that, of course, looks at, the type of campaigns or education campaigns that we can do. And we can be a forum for discussion, something like today. So we really, really do want to hear from you, hear about what you think of these ideas, and what you think how you think we can contribute. The nudge factor is really interesting that Kevin brought up, because we are doing our own research with employers using that behavioral economics and really looking at the incentives and disincentives that drive behavior, and things like opt-out programs where, for example, when you are hired at a work site or by an employer, when you sign all those papers and you do your orientation, you actually would have to sign or opt out of some kind of early intervention coupled with accommodations and an expectation that you would return to work. There are so many great things that you could think about that could provide incentives and help people do the right thing and modify behavior. What are those market drivers and the strategies? We want to really look at the physician role, and I love the way that the three papers work together to kind of map out a process so that we can really look at the flow chart and the different actors that are involved at different points in the return to work, early intervention, stay at work process, so that we can identify the incentives and disincentives that affect each of those players at a different point in time. I think we're getting pretty close to, thank you, Mike. I think we're getting pretty close to being able to develop really good strategies that could lead to evidence-based success, because we know the players and we can identify now what the incentives and disincentives are. And I do think, especially because I'm in the Department of Labor, that OSHA could be a real factor in this, and looking at workplace safety coupled with accommodations and some of the things that we do. And we've certainly started those discussions, so more there. And finally, opportunities. We have the regulations of Section 503 that give federal contractors, 85% of employers, give federal contractors an incentive to retain people with disabilities and hire people with disabilities. But they know that meeting that 7% aspirational goal means also retaining the employees that they already have, but helping them identify that they have a disability early, before a chronic condition becomes something that causes a performance issue. I mean, we really have to look early, and these papers have suggested this. We want to make sure that employers know about accommodations and are offering those to employees, but it means employees have to identify it within themselves and reach out for that help before their chronic condition or disability becomes something that's a performance issue and then creates a disincentive maybe for their supervisors to keep them at work. We also, the Workforce Innovation and Opportunity Act is, of course, another great opportunity because of the focus on people with disabilities, providing better services, training to American Job Center staff, and to young people with disabilities, too, who are going into the workforce system now. So I'm going to stop there, but really appreciate all this great work and look forward to hearing some of the questions and working with our partners on solutions. Thank you.
Okay, I'll have to repeat that. So we have a good amount of time, thankfully, for questions. And for those who do have questions, please state your name and affiliation when posing the questions, and limit your question to just one only. If you're here in the audience, please speak into the microphone so the webinar audience can hear you. And for those attending online, please continue to submit your questions via the Q&A panel, or also via Twitter using the #R2W policy hashtag. Do we have a webinar question?
We do. We have several. And I'll start with Jennifer Christian. The question is from Frank Newhauser. Are you concerned that penalizing employers for workers that leave work due to disability risks reducing the initial hiring of workers with some moderate level of disability?
The way I envision the penalty is not that it has to do with the loss, but that it has to do with the good faith effort and the adequacy of the effort that the employer has made to keep the person. So no, I am not actually concerned about it. It's possible, though, that any law, if it's miscommunicated or misadministered, can have that effect. The ADA already requires employers to hire people with disabilities, so this isn't going to make it any worse.
I'll go for an audience question now.
That's a good question, though, Frank. Thank you for asking it.
Hi, Crystal Blyler from Mathematica. I have kind of a follow-up question to that about the same point, and wondering if it could be a fine for people going on to Social Security disability could be coupled with a reward for hiring people off of the Social Security disability rolls. And if those could balance out so that the employers are rewarded for hiring people with disabilities, even though they're also penalized for being the last employer before somebody goes on to disability. And then a part of that question, too, for Jennifer Sheehy is, what would it take to implement something like that? Who are the players in the federal government that would have to be involved in that conversation? I mean, I'm thinking IRS, Social Security, labor.
Can I first head you off at the task here, which is that I don't think anybody's talking about having a fine because people go on Social Security, because some people have to, right? So the point is the employer actually making an effort? Because what is true right now is employers often don't make the effort. So it's inappropriate and unrealistic to think that people with terminal cancer and people with very, very, very serious medical problems aren't going to end up on Social Security. So what we want to do, though, is have the society functioning with a social safety net with people at every level doing what they can to help people keep their jobs, right? So let me just clarify. That is for sure what we're talking about. I love the idea of having incentives for employers to hire people off Social Security. That's fine with me.
And I think a lot of people who are on Social Security disability at that point, it might be unrealistic to really try to create a whole system that is an incentive for getting people off of SSDI when we really, really need to look earlier. And we should give incentives for keeping people at work or bringing them back, within that time that they're on short-term disability or have just been separated from work before they apply for or are on the rolls of SSDI. I mean, certainly I'm not talking about everyone, because there are some people that need to be on SSDI while they are recovering and in rehabilitation in order just to have that health care and the cash benefits so they eventually can get off. But these are people that know they're going to get off and know that they're going to be on for a short time, and are using it as a supplemental support and not an ultimate goal. But I do think that, the federal partners and the agencies that should be involved are certainly, we should look at tax incentives. We have some tax incentives now, and they have had like moderate success. So I think we should look at the history of the success for the tax benefits that are there. And I think we should do more to work with our partners in the earlier stages, like Health and Human Services and Department of Education and the agencies within the Department of Labor that can really contribute in that earlier space. It's not just a federal government problem, though. I mean, that's why I think the opportunities for incentives and market-driven strategies, I mean, policies, maybe federal policies that really create those incentives for employers, but it's not going to be, we're not going to get a lot more funding for federal programs and benefits. So let's look at how we change policy like the federal contractor policy to really incent employers to do the right thing at an earlier stage.
And I'd like to pick up on what you're saying, because if employers start feeling some pressure to make a good faith effort to help people keep their jobs, they will start making pressure on their vendors to help them do it. And that will transform the way that the disability vendors are working, the workers' comp vendors are working, and that will put pressure on the medical providers to support the stay-at-work and return-to-work process. And when I was talking about making the right kind of effort, I happen to do some case management in workers' comp, and what I see is employers saying, nope, can't bring them back. That's how much thinking they do. Nope, can't bring them back. And helping somebody might include saying, we can't bring you back, but we know a great employment agency, and we'll pay for you to have an evaluation with that employment agency. It doesn't have to be that the employer solves the problem inside their walls. It's simply that they make a good faith effort to help the person land on their feet someplace else. Because right now it's, I can't help you, goodbye.
Thank you, Jennifer. Another webinar question?
Yes, this question comes from Dr. Alan Engelberg. It's, I think, directed to both Jennifers. Do you know of any ACOs or accountable care organizations that have return to work or stay at work as one of their measures of successful health care?
No.
No.
It's not on their agenda as far as I know at all. The conversation, and I was actually just talking to somebody from HHS, the world of the healthcare industry is asleep on the issue of the impact of injury and illness on people's lives. It isn't part of the profession of medicine. It isn't currently part of the world of healthcare, with the one exception being my specialty, which is occupational medicine. And we are only like 2,000 doctors out of the 900,000 doctors in the country. So this conversation, it's a conversation that needs to start between the employment sector and the government sector and the insurance sector, which is healthcare, we need your help, we need you to pay attention to this, and we'll pay you to do it.
So we'll go back to the audience. I want to remind you that Dave and Kevin are also waiting for a question.
Wake up.
Hi, I'm Annette Bourboneer from the University of Rhode Island, and I have a question for Jennifer Christian. I have a million questions, but I have one for you specifically. I think that the knowledge gap for physicians is incredibly large, and what do you see as a way of really closing that gap? And I'm saying this having worked in healthcare for many years, as well as being a healthcare consumer with a disability. And it's not only their knowledge gap about going on and off disability, but I'm also concerned about the rebound effect. If they're doing more paperwork, will that make access to healthcare for people with disabilities more difficult?
Well, your question is perfect. I founded my company in 1998 in order to correct the problem of doctors not having had education in this area. And I had a false assumption in the creation of that company, which was that market forces, employers and insurance companies and government would ask the healthcare system to do something about it and speak with a concerted voice, and that would make me wildly rich. Right? And they haven't done it because for some reason the employment sector, the insurance sector, and the government sector has not sat down with the healthcare sector and said, we need you to do this. Now, in the very limited cases where we have had success at training physicians, it's always been sponsored by an employer, by an insurer, or for some reason by a pretty big healthcare delivery organization that has decided it wants to do it. you're coming from the right state. I happen to be doing a project right now with the largest work comp insurer in Rhode Island, who is bringing together, creating events, introducing the employers who are their clients to the doctors in the communities that are treating them, and getting them together at tables and talking about a shared goal of reducing unemployment in Rhode Island and helping Rhode Islanders stay employed. So it can be done, but it needs this conversation to happen. Healthcare is not going to do it on its own. It's not interested, period.
We'll go back to the webinar, and if we have a question for Dave or Kevin.
I do. A question for Kevin, actually. This question comes from Rebecca Ray. She asks, could you provide more details on the ticket to work to stay at work? Do you see this as a national pilot supported by federal funding? Would it incorporate elements of ticket to work, such as employment networks providing job assistance pre-SSDI?
I can try to provide a little more information, and maybe I'll ask Dave to either correct me or add more details. It would be funded presumably with federal dollars, maybe from the Social Security agency, and the idea is to work through private disability carriers to provide incentives to employers or workers to provide more stay-at-work kinds of services. And I lost the second question now.
The question was, would this be similar to the existing Ticket to Work program?
To the existing Ticket to Work program?
Right.
Yes, it would be similar to that with the same same idea of usually using financial incentives. I don't know, David, do you want to add?
Yeah, well, I mean, the idea has been around for a while. Actually, Monroe Berkowitz, who's known as the father of Ticket to Work, actually included it in his initial proposal, and his idea was that maybe vocational rehabilitation agencies could be given this tool to help their clients get jobs rather than apply for Social Security benefits. And I think the Washington State Workers' Compensation Agency uses something similar to pay employers to rehire their workers or keep their workers back at work once they, after they've had a workplace injury. And I think the idea is fairly simple. It's really paying the employers to retain people, and the question is, how can you implement it in a way that it actually produces the types of outcomes that you want?
We'll go back to the audience here in the room.
Hi, my name is Mary Campbell, and I am actually a return-to-work coordinator for a government agency, behavioral health. My biggest issue is getting the lower-skilled workers back to work once they have been injured on the job or are recovering from a personal illness, encouraging them to go to school so we can do a job transfer, but it's very difficult. And I don't have any incentives to encourage them to go back to school, and then that causes me problems in keeping them at work. The higher skill individuals, easy placement, easy job transfers with available positions. So what kind of incentives can we offer this group of employees to develop newer and higher skills to keep them in the workforce?
Kevin, I think that's primarily
That's a tough question.
When you look at the evidence of the effectiveness of WIA, the Workforce Investment Act, the evidence is quite consistent that the most effective part of WIA is the part that helps disadvantaged workers. Almost every evaluation I've seen of that title of WIA has shown positive returns to both training and other services provided. It's been less sanguine for dislocated workers. So I guess my answer to your great question is sort of the WIA type services, training when it appears that the worker can't otherwise get employment, reemployment services that through the AJCs, American Job Centers, and so forth. The evidence that I've seen with regard to the effectiveness of WIA for disadvantaged workers, I don't recall seeing any breakdown of the subgroups with a disability. So I'm talking about sort of in general the services for disadvantaged folks.
And Mary, are you talking about federal employees or not? Pardon?
The capital of the free world.
It's very difficult to determine this group to teach additional skill sets to remain employed. We understand the military is technical. Some of them don't even know how to turn on a computer.
Based on their job function that they were hired for, however, with the injury or illness that occurred, I'm at a loss to help them remain employed in a different type of job. So I don't have any incentives. What can I offer this group to keep them employed?
Is there disability retirement, like the federal disability retirement?
For some employees, yes, and for some, no. We're a two-tiered
create an incentive
system.
to come
Yes.
back to work. Yeah.
So some, they have no incentive to come back to work, and some who have disabilities want to stay at work, and but most of those employees have those higher sets of skills, and they want to be at work. So, it creates a quandary for those of us who help folks stay at work.
Can I comment on that? One of the things they did in the United Kingdom, when I remember one of my recommendations is that we put together some educational and public communications campaigns, is right now there is insufficient awareness in the American public that a life on disability benefits is a life of poverty, social isolation, family destruction, blah, 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 right? We are very focused on the benefits, the economic benefits of being on benefits, and not enough on what it's going to do to you and your family and your future. So I think the part of the idea is to start shifting the national conversation towards the fact that a life as a productive person is a happier life, a more fulfilling life. We were born to contribute. We're born to be part of society. And the people you're talking about, I think, must be living lives of sort of despair and cynicism, right? I can't do it. I have no role. There's no hope for me. The best thing for me to do is to take advantage of this illness and get a ticket, right? And so it's a soul disease, partly. And so when we talk about transforming healthcare and what the healthcare sector can do is when it sees people who are choosing chronic illness instead of choosing wellness and choosing getting better, is to shift the amount of attention that the healthcare industry is paying to the cost of this chronic condition on your fulfillment and satisfaction in life. Like who I'm here as your doctor to be is to be a person that gives you the best possible future.
Well, and I would just also add, I mean, we look at the whole, the personal dynamics and raising expectations as part of the work in our office too, and I was getting these exact questions yesterday at a different federal government, federal agency event where people really need to see themselves successful in that next job, which means mentors and people that have had similar injuries, have similar life experiences, and come from similar, economic backgrounds or have those. They don't believe it until they actually see it. And so some of those role models and mentors are really making a difference in the work that we do.
David, do you want to add something?
Yeah, just briefly responding to Mary's question in a different way. I think you're illustrating the problem that we've identified, that the incentives aren't lined up to provide and people are falling through the cracks because of the things like you're experiencing yourself. And And I think our recommendations have to do with, what states or districts, semi-states can do under current law if they put their minds to it. And of course, I know resources are limited, and so where are you going to get the money? I mean, that's always going to be a big issue. And I think those ideas would apply in your circumstances as well, and the same would apply to the recommendations for the federal government.
I'd like to go back to the webinar audience for one more question.
Yes, this question comes from Jessica Drobinek. Did any of your groups look specifically at individuals whose disability is not, quote unquote, as apparent? What about individuals on the autism spectrum disorder? Their diagnosis isn't going away, but some days are worse than others. And then what about individuals with mental or behavioral health problems such as anxiety or depression? Did anybody focus on these groups?
I don't think we looked at autism. We were focused on adult onset conditions primarily. We certainly did look at behavioral health, and as I reported earlier, in the literature on early intervention for people with mental health issues is very positive in terms of the things that you're able to do in order to help people stay at work. So I think that was definitely a focus of what we did.
We'll take one last question from the audience here.
Hi. Again, I'm loving everything I'm hearing, just need some specifics. I'm going to re-ask part of the question I had before to Kevin and to the two Jennifers. The thing I'm coming down to are two things. One is source of income, if you're not going back to your job, right? The stay at work thing would work for those. And as Jennifer just brought up, the whole idea of mentors and models and supports and all of that. So I'm wondering, Jennifer, is anybody thinking about extending unemployment for people with disabilities that are having a hard time getting back and will need more training or whatever? Is anybody thinking about getting the CILS, Centers for Independent Living, for those who don't know, or the advocacy member benefit groups for those with whatever injury it is, involved in contracts to do this kind of stuff? And I really, really, Kevin, would love to hear more about this insurance, wage loss insurance thing.
Well, I'll just quickly say that I know in a lot of the proposals on early intervention that are starting to surface, having some kind of cash benefit early as, temporary, time limited with work as an outcome, is coming up as one idea of one of the intervention services and in the models. So who administers that, and whether that would be part of a ticket to stay at work or something that hasn't been defined as much, but certainly the CILS, the Centers for Independent Living, could be really important. First of all, they are everywhere. I mean, there are more than 400 of them. They are run by people with disabilities. They're responsible for kind of networking in the community, so they can they have access to people like mentors, certainly, and they do have an employment role in the new Workforce Innovation and Opportunity Act. So I don't think people have explored that as much yet, but certainly the opportunity is there. Thank you.
I think we'll have to stop here. We hope you've enjoyed today's discussion. Please be sure to let us know how you think we did by completing the comment card in your packets, or the electronic survey offered to our webinar audience. Thank you.
Pushing the wrong button.
There you go.